Welcome to the Deep Dive, where we extract the core knowledge from specialized sources and, well, give you the ultimate shortcut to being well-informed.
And today we are taking a deep dive into a really, I think, often overlooked area of pharmacology.
Antifungal agents. We're
Ah,
moving beyond the usual talk about antibiotics
yeah.
into a whole different world.
A crucial world. We're talking about fungal infections or mycoses, and they are just getting more and more common.
Right, and some of them are pretty minor, like athlete's foot. That's a type of tinea.
Exactly. But the more concerning trend, and what our sources really focus on, is the rise in these serious, potentially life-threatening systemic infections.
And the material lays out exactly why we have to pay attention. It's because we have this growing population of immunocompromised individuals.
Yes. People undergoing cancer treatment, organ recipients, patients with AIDS, and, our growing elderly demographic.
So when the body's defenses are down, these fungi, which are basically everywhere.
They become opportunistic killers. Precisely.
So our mission today is to unpack this. We're going to look at how fungi are different, the main drug classes, and maybe most importantly.
The critical nursing considerations, the safety, the monitoring. These drugs are not to be taken lightly.
Okay, let's jump in with the most fundamental question.
Yeah.
Why can't we just hit these things with penicillin? I mean, they're microbes, right?
Right. If only it were that simple.
Hmm.
The core difference is cellular structure. Fungi are eukaryotes. They're actually much closer to our own cells than bacteria are.
So they have a different blueprint.
A completely different blueprint. A fungus has this rigid cell wall made of chitin and polysaccharides. But the real key, the thing that makes antibiotics useless, is in its cell membrane.
Okay.
It contains a unique steroid-type protein called ergosterol.
Ergosterol. So it's not cholesterol, which is what we have, but a kind of a fungal version of it.
A fungal-specific analog, exactly. And that ergosterol in the membrane is the Achilles heel for antifungals.
So antibiotics just bounce off that chitin wall or have no target.
Correct. And on the flip side, most antifungals are designed to go right after that ergosterol so they don't harm bacteria. It's a really, an elegant pharmacological target.
We should also probably define one of the most common fungal organisms, especially in those compromised patients you mentioned, Candida.
Oh, absolutely. Candida
Yeah.
is vital to understand because it's normally in our system. It lives on our mucous membranes.
It's a normal part of our flora.
It is, but when the immune system weakens or when you wipe out the good bacteria with too many antibiotics,
Candida sees an opportunity.
it proliferates. It causes those common yeast infections, thrush in the mouth. It's the textbook opportunistic infection.
Got it. Okay, so we know the stakes, we know the target. Let's talk about the big guns. Systemic antifungals.
And the source material is so clear on this. These drugs can be highly toxic. You absolutely need to get a culture to identify the organism before starting, if at all possible.
So let's start with the largest group, the azoles. Things like fluconazole, ketoconazole.
The azoles are workhorses, but they come with a lot of baggage. Their main mechanism of action is to alter the fungal cell's permeability.
So they're either breaking down the walls or stopping them from multiplying.
Exactly. They're either fungicidal, killing the cell, or fungistatic, which just holds them in check so the patient's own immune system can take over.
And how do they do that? How do they target that ergosterol?
Well, the older azoles, like ketoconazole and fluconazole, they work by blocking sterols in the fungal wall. But here's the big complication.
Okay.
That blocking action can sometimes spill over. It can also block human steroids.
Wait, like testosterone and cortisol?
Exactly like testosterone and cortisol. This cross-reactivity can create a whole host of systemic side effects we have to watch for.
Wow. So treating the fungus could potentially throw a patient's entire endocrine system out of whack? That's a serious trade-off.
It is. The newer ones, the triazolids, like posaconazole and voriconazole, they try to be more specific. They inhibit the synthesis of ergosterol itself.
So they try to stop the fungus from even building its wall in the first place.
That's the idea, a more targeted approach.
But regardless of the specific mechanism, the azoles are just famous for safety concerns. Let's get into that, starting with the liver.
Yes. Severe hepatic toxicity. It's a huge watch point. We see it with ketoconazole, itraconazole, and even some of the newer agents.
So if a patient already has liver problems,
Their risk just skyrockets. Dose adjustments are mandatory, and you absolutely need baseline liver function tests before you even think about starting one of these drugs.
and then there's the other massive risk, the drug interactions, specifically with the liver's processing system, the CYP450 enzymes.
Oh, this is maybe the biggest danger of all, especially in patients on multiple medications.
Right.
Ketoconazole and fluconazole are powerful inhibitors of that system. Think of CYP450 as the liver's main processing plant for almost every drug you can think of.
So when you inhibit it, everything else just starts to back up.
It stacks up in the body. So if your patient is on, say, the blood thinner warfarin or cyclosporine after a transplant, or an anti-seizure drug like phenytoin,
And you add an azole?
their levels for those drugs can shoot up to toxic levels. And the toxicity comes from the other medication, not just the antifungal. You have to be incredibly vigilant.
The source material also points out some really specific cardiac alerts.
It does. With voriconazole and posaconazole,
Yeah.
you have to be so careful. You can't combine them with other drugs that prolong the QTC interval on an EKG.
That's a major cardiac risk.
A huge risk. And there's another one. Never combine them with ergot alkaloids. Those are often used for migraines. That can cause something called ergotism, which is this extreme, dangerous vasoconstriction.
And just to round this out, the prototype they give us is fluconazole.
Right. Widely used for candidiasis, cryptococcal meningitis. The key things to remember are its very long half-life, about 30 hours, and the fact that it's mostly excreted unchanged in the urine.
Meaning if you have a patient with any kind of renal dysfunction,
You need to be extremely cautious with the dose. You have to monitor them closely to prevent it from building up to toxic levels.
okay, let's move on. If the azoles are so complicated, there must be other options. And that brings us to the echinocandins. What makes them different?
The echinocandins are fascinating. They're a real step forward in targeted therapy. Their mechanism is unique. They inhibit glucan synthesis.
Glucan synthesis.
Glucan is an enzyme that's a key part of the fungal cell wall, but, and this is the important part, it is not present in human cells at all.
That sounds like the perfect drug. Highly specific, fewer side effects.
In theory, yes, it's much more targeted. But the reality is, they're still associated with some hepatic toxicity. Caspofungin, for example, needs a big dose reduction if the patient has liver impairment.
So the liver is still the central clearinghouse we have to worry about.
It's always the liver, always.
Now we get to the heavy hitter. The drug reserved for the absolute worst case scenario, amphotericin B.
That is a perfect description. If the azoles are tactical weapons, amphotericin B is the nuclear option. We only use it for progressive, potentially fatal infections.
Why? What makes it so risky?
Well, it's incredibly potent. Its mechanism is similar to the azoles. It binds to sterols and just blows open the cell wall permeability. It's very effective at killing the fungus. But it's famous for its severe, unpleasant adverse effects.
What's the number one thing the listener has to remember about amphotericin B? The biggest danger.
Severe renal impairment, kidney damage. It's almost a given. It also causes bone marrow suppression. We are basically trading a fatal infection for a guaranteed fight to save the patient's kidneys.
Oh.
And that leads to the most critical safety instruction. You must never combine amphotericin B with any other nephrotoxic drugs.
Like certain antibiotics or cyclosporine.
Yes, or corticosteroids. That combination just multiplies the risk of complete kidney failure exponentially.
It really sounds like giving these drugs requires just as much clinical skill as the drug itself has power.
That's a great way to put it.
So let's pivot to the nursing process. What does all this mean for assessment and implementation when you're caring for a patient on these systemic agents?
Assessment starts with the basics. You check for allergies, of course, but you need a detailed history of any existing liver or renal dysfunction.
Because that's where they're metabolized and excreted.
Exactly. And we've said it, but I'll say it again. Get that culture before starting therapy. And you need a baseline. You need to know their renal function, their liver function, and their complete blood count before that first dose goes in.
And for implementation, what are the big challenges there?
Adherence is huge. These fungal infections, especially the chronic ones, can take up to 6 months to treat.
6 months. Wow.
So patient education is key. They have to finish the entire course. And second, for the IV drugs like amphotericin B, you have to be constantly monitoring that IV site for phlebitis or infiltration.
And what about managing the side effects to keep the patient on track?
Right. For the GI upset, small, frequent meals can help. But you have to check the rules for each drug. Ketoconazole, for example, might need an empty stomach to be absorbed properly.
So you're balancing absorption against patient comfort.
You are. And for the CNS effects, like dizziness or weakness, you have to put safety measures in place.
Okay, what is the single most important piece of patient teaching? The one red flag they have to report immediately.
Signs of liver toxicity. They must know to report a sore throat, Any unusual bruising or bleeding, or, and this is the classic sign, any yellowing of their eyes or skin.
That's a stop everything and call the doctor moment.
Immediately.
Okay, let's shift gears now to local infections, topical antifungals. We're talking about things like tinea on the skin. How are these different?
The main difference is pharmacokinetics, or really the lack of them. These are meant only for local treatment.
So they don't get into the bloodstream.
Exactly. The mechanism is similar. They alter cell permeability, but they are not absorbed systemically in any significant amount. That means the risk of systemic toxicity, those liver interactions, it's almost entirely gone.
That must simplify things a lot.
It does. Contraindications are basically limited to an allergy or applying them over open lesions where you might get some absorption. Oh, and a special note on gentian violet.
Yeah.
It's toxic if it gets absorbed, and it stains everything bright purple.
The prototype here is clotrimazole. Where do we see that being used?
Clotrimazole is very common. You see it for tinea infections, for candidiasis. It comes in creams, but also as a thrush, a little tablet you dissolve in your mouth for oral thrush and in vaginal preparations.
And the side effects stay local.
Mostly, yes. Stinging, redness, some irritation at the site. If you get a little absorption from a thrush, you might see some minor GI upset, but that's about it.
What are the key points for patients using these at home?
Administration technique is everything. Trushes have to be dissolved slowly, not chewed. Vaginal preps need to be inserted high, and the patient should stay lying down for a bit. And for creams, after cleaning the area, you rub it in gently.
And the source material had a big warning about bandages.
A crucial point. Occlusive bandages must be avoided. That includes tight diapers on kids. Trapping that moisture just increases the risk of systemic absorption.
Got it. Okay, finally, let's touch on the lifespan considerations.
Right, because these drugs are often used in the most vulnerable populations.
What do we need to know for children and older adults?
Children are very sensitive, so you need extreme caution. And again, with topicals, never put them over open areas or under tight diapers. For older adults, they're just more susceptible to all the adverse effects.
Especially with the systemic drugs.
Absolutely. With drugs like fluconazole that rely on the liver and kidneys, if you have an older patient with any expected organ dysfunction, you have to monitor them incredibly closely and probably reduce the dose.
And for women of childbearing age?
Because of the potential for fetal toxicity with the systemic drugs, it's standard practice to counsel them to use reliable barrier contraceptives during therapy.
So to recap, we've covered a ton of ground here. The unique structure of fungi with their chitin and ergosterol defenses.
The potent but risky systemic drugs, the azoles and their CYP450 issues, the more targeted echinocandins, and the life-saving but highly toxic amphotericin B.
And the much safer targeted approach of topicals. But the common thread, especially for systemic therapy, is just this constant vigilant monitoring of liver and kidney function.
It is. And that intense monitoring brings us right back to where we started, the opportunistic nature of these infections.
Right.
The fact that poor nutrition or too many antibiotics can open the door for a widespread infection, that means treatment is more than just giving a powerful drug like ketoconazole.
You're saying the nurse's role extends way beyond just administering the medication.
Absolutely. Treating widespread candidiasis means you have to combine the powerful antifungal with intense nutritional counseling and immune support. The pharmacology just fights the immediate battle.
The nursing process has to address the underlying weakness.
Or the infection will just come right back. And that, I think, is the real challenge these agents present to us.
That is the essential insight to carry forward. Thank you for guiding us through this incredibly detailed and crucial area of specialized medicine. We hope this focused summary serves you well in mastering these complex and vital agents. Until next time, keep learning.